Well, welcome again. Welcome again, everyone. So I'm going to start off by hopefully sharing my screen. There we go. All right, we got the right information there, so that's great. So I'm going to be going through this presentation. Hopefully, this isn't the first time you've ever heard of cognitive behavioral therapy or CBT. But if it is, no big deal. We're going to try to give you a good introduction about it and also hopefully some refresher. The biggest takeaway from today, I hope, is that you will identify and be able to know that anybody on this call can use cognitive behavioral therapy at some capacity with your clients. And so I'm hoping that this will be something that you'll be able to take away some of the handouts and interventions and start applying it to clients by next week. So, all right. So some of the training I've gotten, I've done cognitive behavioral therapy my whole career. I'm the vice president of behavioral health. I've been with FireQuest for 7.5 years. I've been a therapist in the field for over 20 years. Actually more than that, but anyway, really passionate about this field and about serving people. What I love about cognitive behavioral therapy is I think it's simple enough that most people that are even new to their career can use some of the principles, and most of our clients can get some of the understanding. It's really about identifying thoughts and what can we do to try to change some of those thoughts. I'm going to break a lot of this down today for how you can apply it with the different populations that you work with, especially people that have IDD or cognitive delays. And many of you that are providing services in the LTCs, I know a lot of people have cognitive delays with that as well. A lot of the material I've gotten through many people through the years, and I'm happy to share any resources. So as we're going through the presentation, if something piques your interest you'd like to know more about, you can either put it in the chat or send me a message afterwards, and I can provide you more resources about any of this stuff. So, okay, let me see if it'll. Our objectives for the training then. So hopefully you will leave here today and understand mental health symptoms in individuals with IDD and cognitive delays, how they may look, learn how CBT can be adapted for this population, and then be able to practice the communication techniques in a therapeutic setting. To start off with, I want to do some identifying of some of the common use terms. One of the most common is IDD, right? Which intellectual developmental disability. Learning disability is a part of that, and it can be a significant impairment of any kind of intellectual ability, which then can show as difficulties in social and adaptive functioning. So these are the clients you guys are working with on a regular basis. You're seeing this play out and trying to understand how maybe your clients are perceiving things and how can best apply the information. We know that cognitive delays are also prevalent in older adults too. So a lot of you that are providing services in the LTCs. And then not only people with IDD, but also people that are having cognitive delays. These populations are more vulnerable to depression and anxiety, which is why our services are so needed. And the population that we're serving, we consider the underserved. Not very many people specialize in this, and we're really trying to help identify these symptoms and hopefully decrease them by helping them learn some coping skills. And a lot of times people in the past that have had the co-occurring cognitive delays have historically been considered exclusionary criteria for psychotherapy. So it used to be, oh, this person has, a lower BIM score, or they have a developmental disability or an intellectual disability. Well, I'm automatically going to say that they don't qualify for therapy. Thankfully, there's been a lot of improvements in this areas with both not only our counseling boards, but also with the Ohio Medicaid and Department of Mental Health Addiction. They've understood and DODD that people with developmental disabilities can also benefit from cognitive behavioral therapy. So we've been able to move this forward then with providing a lot more services, which has been amazing. All right, so overview of CBT. Hopefully, again, this is not the first time you've ever seen this before, but big definition, cognitive behavioral therapy, or CBT for short. Obviously, it makes sense to have it short. You don't have to use a long definition. It has been effective overall, and this is for all the general population. There's been so many empirical studies done on the efficacy of CBT on things like depression, anxiety, and other psychological disorders. If you ask anybody that's a therapist or anybody in the field, they'll tell you that the most commonly used intervention is CBT. And it is one of the reasons it's so common is all the studies and the acceptance. Almost every insurance that I've ever worked with, I think every I have worked with, have accepted this as an intervention, no problem. And they understand that people that learn the basics of CBT in most of their therapy programs. But that's why we're having this training, because most of you that are not therapists have maybe never heard of CBT because you didn't learn it in training, or you may have got a little bit of training in what we do for new hires that are our TBS, and then our TBS University goes through CBT. But we want to make sure you all have the little bit of knowledge about it that you can use it to treat things like the depression, anxiety. And like my next bullet point said in there, people with learning disabilities, they actually have been doing a lot more research on the use of CBT for the people with these co-occurring, which has been amazing. And it's shown that with just a few modifications, CBT can be a successful intervention. And many of you probably already have somebody in mind that maybe you've worked with that research, that support, now that they are actually using this on a longitudinal study and seeing the long-term effects of using cognitive behavioral therapy. And so there's been other studies that have shown that it's also helped in both individual and group for people that have issues with anger, psychosis, obsessive compulsive disorder. I mentioned already anxiety and depression as well. So again, if you're someone that really likes research, just let me know, and I'm happy to send that information to you so you can look more into this. One of the things that we have to do for being a Ohio Department of Mental Health and Addiction provider and also billing Medicaid is all the interventions that we provide have to be proven to be accepted and what we call effective for the type of symptoms that the client presents. And it's not like one day you're going to be all of a sudden just to do an off the wall intervention and that'll be accepted. So we really have to make sure that we're staying within the framework of what's accepted, and not only by our payers, but also by the Ohio Department of Mental Health and Addiction. So that's why CBT, again, is such a well-researched, and they continue to do the research on this, not only for our what we consider our neurotypical population, but also now with people with co-occurring intellectual and development disabilities. All right, Kim is going to launch a poll. So I want everybody to please go ahead and fill out this poll. First question's real hard. What's your position? And then your level of a comfort of applying CBT.
So Anne, while they're doing that poll, there's a couple black boxes on your screen. Could you maybe hide your toolbar at the top if you're able to? It probably is under more.
Is that it?
Okay, yeah, that helped. And then maybe close your chat. If you have your chat open on the right, if you could close that box, that might help.
I also have a question.
Is that better?
That's better, yeah.
Okay.
I have
Yes.
a question. Since I'm team lead, do I still just put TBS?
Yes.
Okay.
Yes.
I just want to make
Thank
sure
you.
I don't want to put other and you're like, what? Okay. Just want to make sure.
Okay, we're almost everybody, just maybe 5 more people. So you guys are real quick with this poll. Good job.
Kim, are you seeing the results showing?
I can see who's completing it, and then I'll share the results when it's completed.
You will.
There's,
Okay, good.
There's 3 more people out there that need to do it. If
One
you
is
have completed it, you may need to click submit if you've answered all the questions.
One might be me, Kim, right?
Oh, perhaps.
If you're waiting on me, I don't actually know how to do that, so.
Okay. All right, we'll give maybe just a couple more seconds and then I'll go ahead and end it.
All right. Are the results sharing on the screen now?
So your screen looks like a black box. Let me share my screen so they can see the results, and then we'll go back to you.
Okay.
Mm.
There we go. All right, can everybody see the poll results? Maybe not. I think that's my screen again.
Nope, I can just read them for you. So we have 22% therapists, we have 59% TBS, we have no nurses, we have 2% NPs, and then 17% others. For level of comfort, 13% of you feel skilled, 32% are comfortable, 26% are moderate, 23% said some comfort, and then 6% said they've never used it before.
Awesome. I love that. I love the breakdown of that. That's really great. I'm going to go back to sharing. So I wrote down that there's 8 people that feel like they're skilled. I love that because so much of this training is really about also just sharing. So I'm hoping that as we're going through stuff, that those 8 that felt skilled would be willing to share with the rest, everyone else, kind of about what's worked for them. And I did again. I forgot to share through the video. There we go. The sound, I mean. Okay, cool. Video panel. I'm gonna get rid of that one. Meeting controls. Okay, perfect. All right. Thank you guys again for doing that. So now I'm gonna go through just some quick overview of some of the symptoms for common mental health disorders and how we're going to apply CBT to them. So the first one is depression. Most of you have obviously heard of depression, but a major depressive disorder is a combination of symptoms that interfere with a person's ability to really function. So things like work, sleep, study, eat, and just enjoying things they used to do, once pleasurable activities. So just a basic overview of what a major depressive disorder is, and then we're going to get into the actual symptoms of depression. So there's a lot listed on here. I know you guys can read them and you've heard of depression. I want to highlight some of them for you. So loss of interest is one of them. So people experience depression often lose their excitement for life. And so if any of you guys have had clients where this has been the case, you can remember what it looks like. Things like hobbies and interests lose their appeal. And while everything might seem challenging or too much trouble, and then it just like seems like so much energy is taken to do the normal everyday activities. This lack of energy and also can cause fatigue, and it's frequently associated then with that depression. So these symptoms are frequently found in people with mild intellectual disabilities. So they usually are able to tell you and you can observe them, but they might be more difficult to identify in people with more severe intellectual disability. And there's no evidence suggests that those with more severe do not experience these symptoms. It's just harder for them to self-report and harder for us, obviously, to read their mind and know what's happening. Sometimes the whole thing of, oh, they're just having a behavior. They won't get out of bed. They're just having a behavior about that. Well, we really need to investigate and see, is it because maybe they're feeling depressed and they're just not able to explain it in a way that we can understand, or we can't communicate to them the way that they can understand, so we can have a better understanding of how the depression might show up in someone with IDD. That lack of energy and tiredness, that fatigue that can be associated with depression, it's not within the person's control, and sometimes that might require them to be able to see their general practitioner or their primary care physician. Things like physical aches, pains are frequently noted also. And often with people with intellectual disabilities, they might have an underdiagnosed physical need as well. So it's really hard to tell the difference between the two. So it's really important that they do have an exam from their doctor, especially when these symptoms might manifest for the first time. They want to look at any physical reasons for the lack of energy and aches and pains before considering depression. And this is where family members carers and friends and you guys might find it difficult to comprehend and be empathetic towards a person's depression and lack of enjoyment, especially when they can see no obvious cause for depression. So they might say, just snap out of it. We got to go. You know, aren't you excited? We're going to do this today. And for whatever reason, they're not able to get going. They don't have the pleasure in being able to go to the daily activities like they used to. And, you know, as someone that works with them, especially the people that are working in their homes each and every day, it might get frustrating. And so we need to be able to show that empathy about what and figure out what's happening with the person. All right, and so then we also have some somatic features, so the physical features I was mentioning that come up even more so for when someone has depression. So the loss of skills due to slowing down or the cognition and bodily movements can be the main way a person presents themselves. So maybe they're slower at doing things, their thinking just seems to be delayed. Things that you're noticing, and you're like, something's off about that person. Things seem slow down. This might include also self-care skills such as hygiene, bladder and bowel control, the dressing and changing clothes. They might actually mean to be relearned following the treatment of depressive disorder. Somatic biological features may occur if the person's experienced depression, things like loss of appetite, associated weight loss, loss of sexual interest, sleep disturbance, feeling of palpitation sometimes, and in severe cases are likely to require sometimes antidepressive therapy and other emotional therapies that we provide. Those who experience somatic features of depression often find that their mood is at the worst in the morning. And then it improves as the day goes on. But so it all depends. And that's where it's important too to get to know what's the baseline of your client. So you can identify days when things might be a little off than what is typically how they typically present during their regular day. Sleep disturbance is a very common feature associated with depression and can be incredibly variable. So meaning they could have difficulty falling asleep and they could also have difficulty staying awake. They could have early morning waking, restless sleep, or excessive sleep. It's really can be all over the place. And so really noting for all those different sleep disturbances is important. And they are also an important feature of depression to note about among those with intellectual disabilities, as it can be apparent in those experiencing depression at any cognitive level at all. It's more likely in this case to be noticed by family members, spouses, and carers. So you may notice more the person is sleeping every time you go to see them, or maybe that they're missing appointments. And so really digging into, is this a different type of behavior for them? Is this a normal pattern? What's happening? So you can really get a better understanding of maybe this is a depressive episode. But depression is often not recognized in people with intellectual disabilities, which makes it difficult, and or autism due to the communication difficulties and the atypical presentation of depression. It's more likely to be common that people with intellectual disabilities than the general population. So much so that it is estimated that mental health conditions are up to 50% more common in people with intellectual disabilities than the general population. Yeah, that's a pretty high amount. So we want to make sure that we are screening and paying attention to these symptoms in every client that we work with. And in people with intellectual disabilities, depression may not be recognized as an illness of its own. And people may see this simply directly to the person's intellectual disability. This is what we call diagnostic overshadowing. Some people, the symptoms may be recognized but misdiagnosed. For example, a person with Down syndrome experiencing mild symptoms of depression may be misdiagnosed in early stage dementia, as it is known that dementia is common among people with Down syndrome. So because you have that knowledge that those two are correlated, early dementia and Downs, you may miss that it actually was depression that was starting. Symptoms of depression may be associated also with an underlying health condition such as hypothyroidism. So it's important that physical health, like I mentioned before, is definitely explored. Now I want to get into the anxiety part. So, anxiety, it's a normal reaction to stress. We all have an anxiety at some realm of the spectrum. I mean, we all are going to have it. But it helps one deal with a tense situation in the office, study harder for an exam, or keep focused on an important speech. In general, it can actually help you cope. But when the anxiety becomes an excessive, irrational dread of everyday situation, that's when it is a disabling disorder. And that's the kind of anxiety we're going to talk about today. Anxiety disorder itself is very common, affecting 15 to 20% of the general population. For individuals with intellectual disabilities, the percent is even higher. Left untreated, generalized anxiety and other anxiety disorders, such as obsessive compulsive disorder and post-traumatic stress disorder, can be detrimental to the person. These conditions may impact their ability to live safely in the community, as well as their relationships, employment, overall adaptive functioning. So it's important to identify what the anxiety may look like. And some of the common symptoms I have on the screen, things like nervousness or restlessness, trembling, I talked about before, trouble falling asleep. It also is very, you're going to see some of these overlap with depression, which makes it a little bit harder to make that diagnosis differentiation. Hyper ventilation, lightheaded, dizziness, sweating, shortness of breath, and then the depressed mood. So yes, depressed mood can also be a symptom of anxiety. So yes, talk about confusing, but it's important to be able to identify what the symptoms are as this person might be having the anxiety and or also depression. So what makes it complicated for someone that has an intellectual development disability is that they're not able to always communicate what's happening. So they may just have their hand shaking all the time and not be able to explain to you that I'm also feeling really nervous, and that's coming, together. That's how that is coming apart, showing their anxiety is that way. So that's where we come in to try to figure out how can we narrow down what's going on with the person. So with this population, it's often a person's behavior that indicates the presence of an anxiety disorder. So they may become irritable, avoid activities they once enjoyed, or they might experience, again, that insomnia or sleep disturbance. If you observe a dramatic change in a person's behavior of someone with intellectual development disabilities, it's important for you to take it serious and get help for that person. So the first thing to do is to explore possible causes for the behavioral changes. A preliminary, like I mentioned before, going to the primary care doctor to rule out any kind of medical issues is important. Because we know things basic as too much caffeine can look like anxiety. I mean, diabetes, other kind of physical issues you could actually misdiagnose as something else. So we want to make sure that they're doing their due diligence and ruling out any kind of potential medical issues. So usually the best interest of an adult with someone with intellectual disabilities is to have someone who knows them go to the appointment with them. This friend or family can explain the symptoms and help them follow up recommendations a physician might make. So I know sometimes, we have our residential or day program staff come along for appointments, which is fine if they're the ones that are with them most of the time and able to identify the symptoms that are considered what we consider to be baseline. But we also have there's a handout. I know a lot of people that are in VRS that will help make sure they fill out before they actually go see our nurse practitioner that lists like symptoms, what's happening, what's normal baseline. Just the more that you can do that for any of your clients will help to make sure when they are seeing either our nurse practitioners or psychiatrists or their family care doctor, that they have the latest information to be able to help pinpoint and isolate what could be the potential diagnosis. So some more symptoms of anxiety that can happen is the poor concentration, frequent urination, irritable mood, muscle tension, lightheadedness. So that irritable mood is one that, especially if it is co-occurring with maybe angry outbursts, can make it really hard to identify if it's anxiety or depression going on, because sometimes it just is labeled a behavior. And so we have to get to the bottom of it and figure out maybe if there's patterns or what maybe might be causing this irritable mood. Because anxiety symptoms that are prominent in people with learning disabilities, all this stuff could happen, but anxiety also could include self-injurious behavior. which a lot of times we think is more so with depression or personality disorder. Symptoms such as excessive worry, like I talked about before, avoidance of a feared stimuli. So let's say maybe someone all of a sudden is scared to go in a car because they had fear about it, or maybe they just saw something on the TV, there was an accident, and so they're thinking about, what if it happens to me? But they're not able to communicate that. All you knew is you're seeing that they are refusing to get into the van, and it seems like they're really irritable. Well, we need to make sure that we're helping, probably working alongside with our residential and day program teams to figure out maybe this is new for them. They never used to be like that. And then seeing if we can pinpoint what might be causing that. The other thing that can happen is anxiety can come across as things like a feeling of choking and palpitations. So, that's scary for anybody in the neurotypical population. And we're able to say, hey, I feel like I'm having a heart attack or I'm out of breath. Or if someone's not able to communicate that, can you imagine how scary that could be? And that could be one of the reasons why they have a real irritable mood, because that's happening inside their body. So irritability again can make it really challenging, and people take it personally. They get sometimes ourselves as well as the residential or day program or the facility staff make it defensive if the person starts getting irritable, and that is only going to make the anxiety worse. And we're trying to prevent that from happening. All right, so now I'm going to have you guys watch a video. I really like this guy. He is a doctor, let me see if I right, Petro, a clinical and forensic psychologist, expertise in delivering treatment to people with intellectual disabilities, autism, and mental health disorder. So the video itself is about, I think, 6 minutes. I think it's good. And then once the video is over, we'll talk a little bit about it.
My name's Luke Hatzipetro. I'm a clinical and forensic psychologist and been working in this area for about 30 years. So we work with people to try to identify what the issues are that bring them to the clinic, and then work together on plans on how to move forward and with the people they live with or who look after them. I'd say 70% of the people I see have an intellectual disability or developmental disability, such as autism spectrum disorder. When I was at university, I wanted to do physiotherapy, but at the time, psychology had been emerging as a course, and I found that it was a lot more appealing, particularly understanding the way people thought and how it affected their behaviours. And at the time of my honours, we had a chance to look at organisational psychology, but we did some clinical psychology, and I did a placement at Ipswich with an advocacy group and found it really interesting. And from that time, I think my first job was with Endeavour Foundation at the Gold Coast, and I think that set the platform. People, who don't have an intellectual disability will come to us and say, look, I feel really depressed, I get really anxious. I need help with it. And so we kind of know that because they can articulate that, they can gain, information from what they're thinking and notice some change. Or people have told them, you're not, you're bad sleep, you're not eating so well. In contrast, 99% of the referrals we get from a person with an intellectual disability is because of their behaviour. So we don't have people with intellectual disability ringing us up going, oh, I'm feeling really sad and depressed, can I come and see you? It's more that they're in the room all the time, they're not coming out, or they're aggressive, I don't know why they're aggressive. And that's predominantly, the primary referral is aggression towards others or self or property. So when we see that, we go, okay, we need to find out a bit more about what's making that aggression occur, or if they're absconding. So that's the other one, like, taking off. Why do people take off from a home they've been there for a long time. So that's the thing that we start with, is the behaviour. But if there's an underlying mental health disorder, then if you treat the cause of it, of the behaviour, then theoretically the behaviour should reduce in its frequency and intensity. That means not as often and not as distressing for the person or the family. However, what we've seen over the years is sometimes people with intellectual disability or developmental disability develop secondary behaviours as a result of the mental health disorder, i.e., so someone who has like a major depressive episode doesn't want to go out. And so one of the things about being depressed is you don't want to go out, you want to withdraw, you're isolated, and you can make that you make that decision as a person. A person with a disability has a carer or a family member we're going to the shops, and if they don't know that person's got depression and that person starts becoming agitated because I don't want to go to the shops, they can do things like slam doors or become verbally abusive, and of course the carer goes, well, what's happening here? This is unusual. And it's not the one-off. It's got to go over a period of time. And this is essential. So, people are allowed to be depressed. It's a normal mood. There's happy and anxious and anger, but it's the persistence of that. So if we have a person in the last month who's getting really angry, really aggressive, they're not wanting to go out, then we think there's a function to that behaviour. And we don't just look at the behaviour, we look then at the person themselves, what's happening around them. And so that's what makes it interesting. It's just not clear cut from the beginning. Yeah, look, explaining what a mental health disorder is someone with an intellectual disability is quite a challenge, because for most people without a disability, they don't quite get it either. How does feeling a bit sad differ from a major depressive episode? How does feeling a little bit stressed differ from anxiety disorder? So I think that the most important thing that we try to do from the outset is develop a therapeutic rapport. So we explain who we are. So I'm a clinical psychologist. We help people when they come in, they feel really sad or they get really anxious, or sometimes they're really angry, they don't know why that. But something's happening in your life that's not quite the same, and we're here to help you do that. So, we're going to ask so we explain the process. We're going to ask you a lot of questions about you, but you can ask lots of questions about me. At the end of it, we'll make another appointment and we can talk more about you. And then we come to what we call like a formulation. So we go, look, we've talked with you, we've talked to mum and dad, we've got some reports from the doctor, and we're pretty sure that you've got what we call like a major depressive episode. Now, would you like us to explain what that is? And the education around what depression is, or anxiety, or schizophrenia, helps people understand. Just like if you and I, were diagnosed with a health condition that we've never heard about, we need the doctor to tell us what's happening and what's the course of treatment. With the goal is we can manage it or get better. Talking about it normally, as you would talk about the Broncos or work, demystifies what mental health disorders is. And you're still a great person. And that there's Joe the person, and there's Joe's got depression, but depression doesn't define Joe.
All right, I'm going to stop sharing just for a bit, and I want to make sure there's anything in the chat. Black box, you talked about it again. Okay, sorry. Kim, I thought I got it. So anybody have any comments or questions about anything that we have went through so far? As far as like how depression or anxiety may look like for someone with a developmental disability or a cognitive delay. Anybody have an example of seeing this personally that they would like to share with the group? How about, has anybody been able to help somebody to understand and learn, identify what their depression or anxiety look like.
Hi, Anne, it's Shanley.
Hey, Shanley.
Hi. So I haven't really worked a lot with people with developmental delays or intellectual disabilities, but I have worked with children. And I think exploring emotions with children can be tough. So I use a scaling system where I explain or psychoeducate that about mindfulness and thoughts first. So we talk about like being present in the moment and what happens when our thoughts drift to the future and we're having worry about things that could happen, that might happen. What could that cause? That's what anxiety could be. And then on the opposite side, if our thoughts drift to the past, it could more often than not trigger depression. Now, those are not like mutually exclusive, obviously, but just important for them to be aware of their thoughts and where they're going and how it's tied to their feelings.
Yeah, agree. That's great. I appreciate you sharing that. Anyone else want to share a time that they helped to explain maybe what depression or anxiety look like to someone with a developmental disability or cognitive delay?
There's a couple comments in the chat. Sean said, I learned that frequent urination was a symptom of anxiety. Piece of new information there. And then Maya said, helped with my youth, but being able to recognize a feeling to a specific color.
Oh, that's
So,
great. I like
interesting.
that. Yeah. Awesome. All right, I'm gonna keep going back on here then and share. Hopefully we're back. I don't know why I keep hiding the screen and I don't know why it keeps coming back up, the floating meeting controls, so I don't know. Anyway, we're talking about the biosocial influences then. So development of depression, anxiety in people with learning disabilities, so there are some psychological influences that happen. And so today we're going to really briefly talk about just 3 models. We're going to spend a lot of time on cognitive behavioral model, self-control model, and the learned helplessness model. Because we want to look at, like I mentioned before, like there's some genetic predispositions that can happen and other factors that play a role in the development of anxiety and depression with anybody. But then there's also more so for people that have the pervasive development disorders. So it's interesting, the fact that we can say, I think one of the statistics was over half the people that have developmental disabilities probably have depression. When people experience trauma and anxiety at that rate or higher than the regular population. So what's the reason behind that? So we try to look at things through a model or theory to see if we can make sense of it. That really just helps drive how are we going to work on treatment. So the first one is that self-control model of depression. So that's where, looking at what depression is a cognitive behavioral deficit in self-control. So being able to control what's happening. And so, looking at self-monitoring. So the individual selectively attends to negative aspects of an experience instead of the positive, and it immediately assesses outcomes rather than long-term. So how they're saying people get depression because, and again, this came from Realm, that they're seeing all the information coming in, and all the information coming in, they're only able to really pinpoint the negative stuff. So all the positive stuff that might be happening in their life, they're not able to monitor as much through that. It's more so through the negative lens. And then we look at self-evaluation. The idea with this is that the individual will evaluate themselves using harsh or very strict standards. So the individual will attribute positive outcomes to external factors and negative outcomes to internal. So, the reason this didn't happen is because I'm a loser, or, I'm no good at this. And the only reason it worked is because somebody on the outside had more control of it than me. So everything through themselves is considered in a negative light. And then we have self-reinforcement, where the individual will provide them with an insufficient positive reinforcement and excessive punishment. So the thing that's being reinforced is a punishment model, like I can't go to that activity. I don't, I should be punished because whatever happened, instead of looking at the actual positive aspect of it, getting stuck in that negative self-reinforcement. Again, that's a really quick overview about self-control model of depression. The next one then is talking about that social isolation model that can be a part of it. So limited or lack of social contact could actually result in depression. So we see this a ton with all the clients that we serve. You know, the majority of our clients in long-term care settings, you know, I would say it depends on the facility, but I would say about 50% don't get contact from their family. And so there's a limited contact. And so, you know, they really have to learn how to become engaged in activities within the facility. Same thing with the people that we serve that had developmental disabilities. So they just have that limited social circles that might happen. And that could be like lonely feeling from the lack of intimate relationships, changes such as moving to a different home, a different LTC or day program might trigger depression or anxiety, and loss, death, or change of worker could also have similar affects. Then we have our learned helplessness model of depression. So the individual's ability to influence or control their reality are perceived to be uncontrollable. And this happens a lot with our people that we serve that have intellectual development disabilities. So where the idea is that the individual is, things are way out of their control, that they don't have a choice. They don't have much to say about what happens to them in their care, that it's all about what other people are doing. So they have a belief that it doesn't really matter, you know, basically where we go today or what we have to eat today, or does it matter who comes into my home, because someone else has determined that. Especially if someone's in a residential environment, they're usually not allowed to speak up and say, I don't really like that, or, you know, I don't trust this worker. It's, well, that's who we have to work here today. So unfortunately, it can be that learned helplessness model that happens. And then once the helplessness is learned, it can lead to expectation of adversity and prediction of negative outcome in the future situation. You know, when we think about workers in like a nursing assistant or a residential provider, they're high turnover positions. And so the person might be used to just that's just how it is. I don't have control. I'm going to have people that, you know, control my most intimate parts about myself that are going to come and go. And so they just learn that it can be a part of and become the way that this particular theory believes could go lead to that feelings of depression. Does someone have a question? Okay. So then the last thing I want to go, and we're going to spend the rest of today talking about, is a cognitive behavioral model of depression. So this is a traditional model. It, again, has been very well researched. It's primarily based on the ABCs of cognitive behavioral therapy, which is A is activating event, B is the individual's belief and thoughts that comes from that event, and then C is eliciting certain emotional or behavioral consequences that can happen. So let me double check. Yeah, someone had a great quote. I appreciate the information regarding diagnostic overshadowing. I think that's important to know and keep in mind when working with IDD population. Agree. So thanks for that point. Okay, I'm going to do another video. I love to involve lots of resources just so that you guys know that it's not just me trying to lecture to you, that there's lots of research on cognitive behavioral therapy and that you can go to after this and get more information. One of my favorite resources is Therapist Aid. We do have like an actual agency subscription to it, so we can like make handouts more specific and, you know, change things around. So, you know, let me know if that's something that you're using and we can look at doing that as well. So I'm going to, should be the next one. Yes. This is a short video, but it really goes into an introduction about cognitive behavioral therapy.
Hi, my name is Woody Schull. Today, we're
Sorry, I'm going to try to move this first. Do that'll work.
going to talk about the ABC model of cognitive behavioral therapy. The ABC model helps us to explain why we think the things that we think, why we feel the things that we feel, and why we do the things that we do. It's valuable to understand the ABC model because once we understand how our thoughts, feelings, and behaviors interact, we gain the power to start changing them. The ABC model looks like this. First, there's an activating event. An activating event is anything that actually happens to a person. It's just any situation that you encounter. Let's go with the example of running into a friend at the grocery store. You see them in the produce section, you say hi, they say hi right back, and then they return to searching for the perfect banana. That's the activating event. It's the fact of what actually happened. Next, we have beliefs about the activating event. Beliefs are what we think about the situation. Two people might have different beliefs about the exact same activating event. What are some different ways that we can think about the situation at the grocery store? One person might think, I must have done something to upset my friend, they're totally ignoring me. Another person might think, my friend is really involved in finding that perfect banana, that's their business, I'm just gonna move along. The truth is, both of these ways of thinking are possible. We don't actually have evidence either way. Our beliefs usually happen so quickly that we aren't even aware of them. We don't take a second to stop and think, was there evidence for that? This is where things get interesting. Someone who's depressed is more likely to have a negative thought about any situation. Someone who is not depressed is more likely to see the same situation as either neutral or positive. Finally, we have a consequence. The consequence is the result of our belief about the situation. This can include how we feel or what we do because of our beliefs. For example, the individual who felt that their friend ignored them, they might go home feeling hurt, and they might not talk to that friend for a while thinking that they were upset with them. On the other hand, the individual who thought that their friend was just acting funny for no good reason, they'll probably forget about it, go home feeling just fine, and they might call up their friend that evening to check and make sure everything's okay. The consequence stage of the ABC model has an important effect on our lives. The individual who felt ignored by their friend will probably end up having a worse relationship with them, which will further reinforce the idea that they've done something wrong. Now imagine this same pattern applied to almost every relationship and every situation that this person encounters. So that's how the ABC model works, but how can we use it to our advantage? It's not easy, but with practice, we can learn to intervene at either the A, the B, or the C to better control our thoughts, feelings, and emotions. We can intervene in the activating event by avoiding situations that we know usually turn out badly for us. For example, if there's someone that you spend time with and whenever you do, there's some horrible outcome, you might recognize that you should probably spend less time with them. Sometimes that just isn't realistic. In these situations, we can try to change our belief. Going back to the example at the grocery store, the individual who felt that their friend ignored them, they could stop and think, is there really evidence that my friend doesn't like me? Or am I just assuming that? Finally, we can intervene at the consequence. We can do this by learning skills such as deep breathing or meditation to help us manage our emotions, maybe reducing depression or anxiety. Thanks for watching. If you like this video, share it and subscribe to our channel down below.
Here we go. All right, so quickly, cognitive behavioral model of depression then came from Beck. He suggests that the core beliefs or schemas are the root of depression or anxiety, and then they often will actually make and proceed the pain-inducing and self-defeating attitudes and behaviors despite evidence that the beliefs in self are false. So core beliefs are developed in early childhood and are typically deep-rooted and rigid. Things like, maybe one of the core beliefs would be that I can't trust a man, or I should be scared of dogs, or I should be scared of snakes. I don't know, there's on and on, like these core beliefs that you could think of that maybe you have that you're like, why do I even think this way? It's probably because it was deep rooted in the way that you were raised or other beliefs that you had as an early a childhood. New experiences then are filtered through those beliefs, and only information that support them could be retained. And that's where the schema or that core belief can be reinforced. All right, so a schema will govern the way that we interpret the experience. And when the core belief, let's say, is irrational, it can lead to a number of thinking style errors, where the sufferer may eventually become caught down in a downward spiral of automatic negative thoughts that they're no longer capable of challenging. So, I'll go back to some of you know that I have a little fear of spiders. I'm not really sure where that came from, but it can cause me to feel a little anxious about when I'm around spiders. It's a belief that I know it's irrational, and I'm usually just fine with being able to, use another challenge that belief and can change it. But eventually, what could happen is if, let's say, for example, I got bit by a spider, that actually would reinforce my belief, and I may never be able to get over that fear, which again could lead to depression or anxiety because it's a core belief that I have. So that's just one example of that. So the cognitive triad is another really common cognitive behavioral term. So if you've heard of that, this is what it means basically. Triad, three parts that continually go around. So you have the automatic negative thoughts that can occur in three domains. You have the self, the world, and the future. And so these are the negative views about the world, negative views about the future, negative views about self that can go on and on as it gets into our thoughts about what's happening, this continual cognitive triad. So the negative view of the self, things could be that, I'm inadequate, unintelligent, or incapable. And then so what can happen is I think unpleasant experience or events occur as a result of my own personal inadequacies. And then a negative view of the world is I believe the world itself presents obstacles that are too difficult to overcome. So if I think the world is too difficult to overcome, then again, that goes to that cognitive triad. So I'm going to think myself that everything is I can't overcome it if I can't overcome the world. And it continues to go on through the cognitive triad. So this is a real quick kind of like, hey, this is the model for cognitive behavioral therapy in order for you to be able to kind of understand how does it all work together. So we talked about the ABCs before, but we want to start with the first thing is that core belief of schemas that develop during early childhood. Because how I perceive an activating event, again, often goes back to my lens. How am I viewing the world through my beliefs that I had as a child? So if going back to that grocery store where, her friend was looking for a banana or whatever, and the one person had perceived it as negative, my core belief during childhood might be that I'm not someone that is maybe worthy of other people's attention, especially in a social setting. So in a social settings, maybe I was learned, or my belief is that I shouldn't have any interactions with people when I'm out in a social setting. So then I have an activating event that's in a social setting, I'm going to see it through that lens. And so the event happens, the activation of the cognitive assumptions or thinking errors can happen. So the beliefs, positive, negative, however one you see it, can happen. And so my belief is that it's automatically negative. If I interact with someone in a social event and I'm not supposed to interact, it's automatically going to be a negative thing. And then there's going to be the activation of automatic negative consequences. One of the consequences might be that I have a panic attack because I can't handle, I'm not feeling, so I'm feeling this in my body as well as I'm feeling the anxiety that might come up. It might be that I just get up and run out of the store. It could be that I automatically get really angry and I decide that I no longer can be friends with this person because, oh my gosh, they saw me in a social settings and I'm not supposed to see people in social settings. Going back to that core belief in childhood. All these things that can happen. Well, then when I have this anxiety and depression, again, that is either going to confirm my existing irrational thoughts. The next time my core beliefs about that situation is going to either be stronger or less because of how that circle happened. So if I had the experience that actually backed up my fear that, oh, I shouldn't be around people in social settings because in childhood that was something that was maybe ingrained in me. And then I had this event happen and it was not, the consequences was negative, right? Like maybe the panic attack or feeling more anxious or whatever. Or maybe that friend laughed and I thought they were laughing at me. Then the next time I have a similar situation happen, it's going to be worse because I just reinforced that my core beliefs were correct and it just spirals out of control. Where if at anywhere along this lines, I'm able to stop my beliefs or I'm able to change my consequences, then the next time and I go through the lens of my core beliefs, I'm starting to be able to, be able to doubt those core beliefs and maybe develop different types of beliefs that again will then affect the way that I go through the ABCs next time. It's very, I know, so easy to explain, but when you're actually going with and helping somebody go through this, and real events that are happening, remember they're experiencing the anxiety and depression, like we went through all those symptoms in the beginning. So they're going through these symptoms, they don't feel good. And so sometimes as people are going through treatment and you're using cognitive behavioral therapy, it actually might feel worse for them. So it's really important that you talk to them about how are they going to cope when some of these symptoms come up to be able to help them as they're going through treatment with you. All right, so we're going to talk a little bit about cognitive distortions. So I'm going to check on time where we're at. Okay, we're right at 2 o'clock. So we're going to go through cognitive distortions, and then we're going to get into some homework. So what I'm trying to do, guys, please feel free to take breaks whenever you need to throughout this. And I know our training is supposed to last till 3:30. I'm trying to end it as close to 3 as possible because Rich did want everybody to enjoy the weekend. And so he wants you guys to have a quick, be able to get off work as close to 3 as possible today. So I'm going to try to get through stuff, but we're probably not going to take a formal break. So just take it throughout as we go so we can continue to keep moving forward. All right, so our next one is going to be about cognitive distortions. Oops. I think I need to hide that first.
When I was in school, I hated giving presentations. They were just the worst type of assignment, in my opinion. I'd stumble over my words, forget what I wanted to say, and they just always felt like they went really poorly. But then I'd get pretty good grades. And I didn't ever understand how that was happening. How would I feel like I did so poorly, but then I'd get good grades? Well, eventually I learned this is caused by something called cognitive distortions. A cognitive distortion is a type of irrational thought where you see things as a bit more negative than they really are. Now, cognitive distortions are completely normal. Everyone has them. It's just part of being human. But when they're too frequent or too intense, they can contribute to problems like depression and anxiety. So today, I want to tell you about 5 different types of cognitive distortions. The first cognitive distortion is called emotional reasoning. This is when you feel something so intensely that you start to think it must be true. For example, think of someone who has a fear of flying. They know the facts that flying is safer than driving, but when they take that first step onto a plane, the fear takes over and they start to think, oh, I know this plane is going to crash. I know it's going to crash. Of course, the feeling doesn't have any bearing on the facts, but if you feel it strongly enough, it'll start to seem true. The next cognitive distortion is called disqualifying the positive. This is when you look at a situation with both good and bad aspects, but you sort of push that good stuff aside and you just focus on the bad stuff. So imagine you get a performance review at work. It says, great job, great job, great job, needs improvement, great job. You look at that and all you see is needs improvement. You forget about all the positive feedback. Another good example, imagine you go on a first date, everything is going well, you're getting along, you have a lot in common, and then you say something really stupid, you just put your foot in your mouth, and you wish you could unsay it. Well, when you get home that night, that's all you can focus on, that stupid thing that you said, and you sort of forget that you're getting along great and having fun. That's disqualifying the positive, when you only focus on a small negative aspect of some situation. The next cognitive distortion is called mind reading. This is when you make assumptions about other people's thoughts or their intentions or behaviors without really having enough evidence. So imagine you give a friend a call, they don't answer, and you start thinking, oh, I bet they had picked up the phone, saw it was me, put it back down. Or I bet they're hanging out with someone else they like more, or maybe they just don't like me. And that's mind reading, when you make assumptions about why someone does something or what they're thinking or feeling without really knowing. The next cognitive distortion is called all or nothing thinking. This is when you see things in extremes, nothing in between. They're either black or they're white, they're good or they're bad. On a more personal level, this might mean I'm beautiful or I'm hideous, I'm brilliant or I'm a moron, I've got a great job or I've got a terrible job. So for example, think of someone who seems to have a pretty good life. They've got a good job, close friends, hobbies they like, they're healthy, but their romantic relationship is sort of on the rocks. Now, most people might look at this life and think like, oh, that's great, they've got a good thing going. But they look at their own life and they think, my life's a mess, I'm such a loser, all because of that one thing. That's all or nothing thinking. When you reduce something to its extremes, just seeing the black or the white without seeing that gray in the middle. The final cognitive distortion I want to talk about today is called catastrophizing. This is when you only consider the worst possible explanations for something rather than the more likely explanations. For example, imagine you're waiting for a family member to get home from work, they're 15 minutes late, and you start thinking, oh, they must have been in a car accident, why else would they be late? When in reality, they're just stuck at work for 15 minutes or stuck in traffic. And that's catastrophizing. You jump to the most drastic explanations without considering what's more likely. Now that I look back at my own experience giving presentations, I can see how cognitive distortions played a role. You know, my presentations, they weren't perfect. I'd stumble over my words and forget a few things, but it wasn't a big deal. In a 20-minute presentation, it might have been 2 or 3 minutes that were a little choppy. Now, the good thing about cognitive distortions is once you learn to spot them, you can start to challenge them. And by doing this, you can change how you think and you can change how you feel. And in the long run, this will improve your mental health.
All right. Hey, you guys are still alive, hopefully. I want to show you, Kim's going to put in the chat. So Kim, put the one that says cognitive distortions therapist aid. And then put the one that's there's going to be 3 altogether. Another one is just cognitive distortions, and then cognitive distortions with answers. So I want to share some of these guys with you guys. Next. Okay. So for when I have done therapy in the past and have went through and used cognitive behavioral therapy, I found cognitive distortions one of the most important tools to go through, because most of us as in the here, as well as our clients, at some point have had some cognitive distortion. And so if you're able to help them with some of these worksheets and help them to see that maybe they have, experienced something similar to this, it might help. So the first one I wanted to go through, this is the one from Therapist Aid. So like he went through like some of the irrational thoughts. So if you're able to kind of go through and figure out if they maybe have any of these type of patterns of thinking, it might help them to see that this could actually go from one to the other. So one of the ones I used to use all of the time with clients is jumping conclusions and then the fortune telling part of it. So the expectation that situation will turn out badly without adequate evidence. So if someone is saying, I don't want to go because this is what's going to happen, then you kind of talk about like, what do you think is going to happen? Tell me the evidence that supports that, and going through and figuring out if there is a potential stuckness part in a cognitive distortion to see could there be another way to address that. And then the other one I wanted to look at is cognitive distortions with answers. And so again, this is just another resource that you can use to with your clients. So this one, again, is just another resource. It's called, I think, Get Therapy or something. At the bottom, I think, has a website. But this one I like because it actually goes through and it talks about, okay, so my mental filter. If I'm seeing everything through dark, gloomy glasses, or only seeing the negative stuff coming in, it goes through questions. And it's like, okay, so am I only noticing the bad stuff? Am I filtering out the positive? So trying to help them understand, sometimes the people we work with that have cognitive delays, things are much more black and white. So having glasses, you could actually show, let's try to take your glasses off. Do you see things differently? I know I've had clients before where we actually had sunglasses in session. And I would say, let's imagine you're seeing everything through these sunglasses, these mental filter. And now, eventually we get to where they're identifying the glasses are associated with the way they're seeing the negative stuff coming up. And then eventually when they're able to take the glasses off, they're able to see that, oh, there's actually so many more possibilities here that I was only seeing things through this negative lens. And it opened up their possibilities. So things with prediction, mind reading, judgments, things like that. I like mountains out of molehill, exaggerating the risk of the danger, or minimize the odds that things will actually maybe turn out okay. And so thinking about, how does someone else see it? And maybe what's the bigger picture? Am I only just seeing this right in front of me? But really, if I take a step back, that mountain's not too big. And so one of the ways we could help our clients do this is actually have them draw a mountain and draw it from a different perspective to see, well, that looks huge, right? Maybe you're the person right next to it. But if you take a step back and now the mountain is this small, it's not really that big. And I can actually see over it. And it's not as powerful as what I gave that thought to be. So the more that you can put pictures with things to be able to help our clients as we're going through the unhealthy thinking habits. And I have more examples of this that I'll be showing later for people with developmental disabilities to allow it to be kind of black and white as you're going through things.
And Chelsea had her hand raised.
Yeah, Chelsea.
I totally didn't mean to hit that. I'm so sorry. I meant to close the chat and it moves over. I'm so sorry.
No, it's okay, Chelsea. So since you're on, I know you used cognitive behavioral therapy before, right?
Oh, of course. Yes.
Yeah. So have you worked with any clients that had any cognitive delays, and how have you modified things to try to help them to be able to participate more?
Oh gosh. I feel like I'm trying to think of some specific ones. I mean, I work with a client right now who he's very, I actually just got a session with him. We're working very hard. He tends to over exaggerate a lot in situations like, oh, well, this person in my life, he didn't say this, but he meant this, or something like that. And so we kind of have to peel back the layers a little bit and be like, okay, where do you think this is coming from? What's making you feel like this? And there's a lot of, he feels like he doesn't have a lot of control in his life, and it's huge. He's 26. He still lives with mom. So yeah, yeah, we're peeling that apart for sure.
Good. That's awesome. I appreciate you sharing that. And sorry, I'm putting you on the spot, but so many of you guys are so much better at doing this than me. So, okay. So I'm going to go back to the screen. Got it here. Okay. So we're going to actually start practicing this. We're going to practice these. Hopefully these will be pretty basic. That you could use some of these for yourself for understanding it more, as well as adapting it for people with cognitive delays. But I do have more handouts, again, like I go through, that actually breaks this down even more kind of black and white for people with cognitive delays. So two people experience the same situation different ways, like he mentioned about the store and the banana and stuff like that. And he also mentioned this as far as the negative evaluation at work. So Jason says, I can't do anything right. I bet I get fired because of this. He's nervous, depressed, and then the behavior. So remember the ABC, he avoids the boss because he believes in trouble. He feels nervous the next time he's confronted with challenging work and performs poorly. Well, Kurt, on the other hand, the same exact situation happened. So the activating event was the same, but his thought was, I guess I didn't work hard enough. I'll have to come up with a better plan for next time. So his emotion is disappointed, but he's motivated. And then his behavior is he actually seeks out the boss to talk about how he can improve. And he approaches his next task as a challenge and gradually improves. So maybe you can put yourself in Jason and Kurt's. I think we've all probably gotten evaluation at some point at work. It's really, this is kind of where you are able to start seeing the difference. We could very easily have gone either one of these depressed and nervous, or disappointed but motivated. But the behavior is, you see how because you change the emotion, the behavior now can change. And then again, that becomes a new cycle. So the next time it happens, the thought that occurs can be more rational each time. Another one. So Gwen and Shirley both have an argument with a close friend. Gwen says, right away, negative. We always argue. Why can't she ever see my side? This is so unfair. Her emotion then, remember the activating event, and now she has the behavior and then the consequences. So her emotions are angry and blaming, and the behavior is she stays angry with her friend and does not reach out to repair the relationship. Over time, Gwen's relationship becomes more and more toxic. Well, Shirley, same thing, had this argument, but said that was rough. I should apologize. We can both be stubborn sometimes. The emotion then was forgiving and regretful. And then the behavior is Shirley accepts a portion of the responsibility, and she actually apologizes to her friend, and they communicate and continue to strengthen the relationship. All right, so now I want to hear from you guys on this. So Emily's cut off by another driver and has to quickly hit her brakes. Her first negative thought, what a jerk. They don't care about anyone but themselves. I could have crashed. The emotion was anger. And the behavior is Emily drives aggressively to provoke the driver who cut her off. Emily is still angry when she gets home, and then she yells at her family. Well, instead of that negative thought, I want to hear from you guys as far as what could have been a rational thought that she could have had instead. Yeah, Stephanie.
Hi guys, it's Eddie. I go by Eddie.
Oh, I'm sorry, Eddie. Yes,
No,
yes.
you're fine. This is what I tell myself because I live in Kentucky. It's pretty hectic out here on the roads. I use humor. So sometimes I say, gosh, they must have to go to the bathroom. And I tend to slow down a little bit. I'm laughing, I'm smiling, and I'll let them over because they need that space more than I do.
And what's then is your emotion and behavior? Your
I'm
emotion.
usually laughing. I turn up my radio, I'm smiling, and I just continue on my way.
Okay, thank you. Awesome. Great example. I love that. Anyone else have an idea of how they might respond? Luke.
I think it's important maybe to give them the benefit of the doubt, you know, instead of trying to like blame them for something or kind of like put them down in a way. Maybe just be like, oh, maybe they had like an emergency, you know, or something like that to try to, yeah, give them the benefit of the doubt, you know.
Yeah, so what do you think would be the emotion and behavior then if you're giving someone the benefit of the doubt?
Maybe like compassionate would be the emotion.
Good.
And then the behavior would be to, yeah, maybe think about a different situation, you know, or put your attention towards something else.
Yeah, I like that. Thank you. All right, I thought I saw one more hand. Let me make sure. I'm not as good at doing this. All right, well, anyway, you guys get the idea. What we're going to do now is go into breakout rooms. And so if you could put CBT practice exercise, Kim, in the chat, and that's what you guys are going to fill out. We're going to break out in 2 rooms. And again, we're not taking an official break today. So if you need to go to the bathroom, you can do that real quick right now. Otherwise, when you get to your breakout rooms, please turn your camera on and have a discussion about this. This is where you're actually going to be practicing CBT, because again, the idea is you leave here Monday, you start actually using CBT with clients. So if you have any, you're not sure, remember we have lots of skilled people on here that could help. But just go ahead and fill out these worksheets and making sure that you can understand how you identify where you can change a negative thought to a more rational one.
Okay, so Anne, you still wanted to do about 6 minutes for this one?
Yes, we'll do, we will do, yeah, 6 minutes. Yep.
Okay.
You didn't, you realize you didn't have what you needed. What was a belief you had? Come on, someone share.
That we were being tested.
Okay. Yes. And so what was your consequence?
We just decided to make the best out of it by just talking.
I love it. Some people probably said, well, heck this, I'm going to go take a break, or I'm going to complain
No,
about it, whatever.
I
I
don't know.
didn't have it, but the young lady I was partnered with had it, so she read it to me, and then we just worked on it that way.
Awesome. That's
Yeah,
great.
yeah. My group, there was two of them listened, but two of us obviously, me, I talk, and so did the late girl I was with, and I think it was a great. We had it. I think we all had it. At least her and I did. So it's kind of interesting that we were able to look at that, and at first we had no idea what we were supposed to do,
Mhm.
because I don't know. I hate to. I don't know why. I mean, I didn't quite hear, but I'm a man. I never listened to women, anyways. You know how it is. But we talked, and I think that the thing once we got into what we were doing, we got into actually talking about how we would do it or what to do and stuff. So it was good.
All right. Yeah, Willis, you're fighting people's core beliefs here by saying that.
I don't mean to do that. Sorry, guys. Once you get to know me, you know I do that.
Well, I wanted to, it was an experience for everyone. I'm glad you guys had an opportunity to at least maybe talk to each other. I wanted to share, we're not going to go through kind of like what you went through in there. Instead, I wanted to show what a handout that you guys are all going to get about how you might modify this for someone with a intellectual development disability or any kind of cognitive delay. So the way that this starts off with is it has, okay, can you guys, does everyone see where it says thought, feelings, and behaviors? Someone just say yes.
Yes.
Okay,
Yes.
awesome. So you're gonna all get this. So you'll help the person to be able to, we're going to first go through and help them arrange what they think is a feeling, a thought, and what people do or a behavior. So, the feelings of anger, obviously happy, but going through like all this stuff. And again, so this is just a starting point, and then you can modify them for what's going to work out well for your client. So once you have that figured out and they have identified it into the three different categories, the thought, feeling, and the behavior, then you're going to go through the worksheets, just like the one you just did, but this looks a little different, right? So the first thing is, what's a situation I really enjoyed? What happened? So what was the activating event? What did I do? And what did I think? How did I feel? And this is where you're going to use the pictures they cut out, and you're going to help them put it in there. And again, you start with a positive to help them kind of flow through how, you can use cognitive behavioral therapy even to identify positive things happening in your life. And then you go to a bad time. So what was a situation that was hard? So what happened? What was the activating event? And then we go into, okay, what did I do? So sometimes it's easier to start with the behavior. So what did I do? And then you go to, okay, so now let me think about what was my belief? So how did I feel? What was my emotions? What did I think? And you walk them through the ABCs using those worksheets to help fill in this. So does that help you guys to see you could modify this and make it much more simplified, maybe for someone with cognitive delays? And then you can go on and make it even further. So this is also going to be a scale that you can use with them to help them with looking at any of those, like we were talking about, those cognitive distortions. Things like, how often do you know what other people are thinking? If they're going to say, I always know what other people are thinking, then you have a cognitive distortion of mind reading that you're going to work on. I expect things to go wrong all the time. So maybe that's a mountain out of a molehill. Where are they at with that? Do you think people are stupid or a bad person? Until you kind of go through, again, this is all about those cognitive distortions that you'll be able to work on with them. So I wanted to show you that you're going to have all these handouts going to help you to be able to modify, hopefully, with people with cognitive delays, to be able to modify the typical CBT to be able to approach that way. And I wanted to, any questions or comments about those handouts at all? Okay. And so then another one I wanted to show real quick was this one, which is again using the whole cognitive behavioral model, looking at what happened, what do you think, what do you do, how do you feel? and showing the patterns and how they work together. And then we get into looking at it for anxiety. What would be an example of how you could go through that? And then also about anger, what that might look like if the person's experiencing the anger. And then we get into actual resource for them about how can you explain what depression is to someone with cognitive delays. And so this is a handout you could go on, work on with them. And again, just some of the, I like some of the they're actually using the models in this are people that have cognitive delays. And, you know, sometimes you can see it from their presentation, but feel free to use whatever pictures and drawings you think might be helpful for the person that you're working with. So this one goes through depression, and then it goes through what's it actually, what are the reasons people get depressed, how anyone can get depressed, and then going through anxiety. And what does anxiety look like for people? And then, I'm sorry, I'm scrolling again. You're going to have this. I just want to show you at the very bottom of this, some signs of anxiety. So sometimes people we work with have cognitive delays. If you say, you know, people have to use the bathroom a lot, they're not, maybe not understanding that. But if you show, remember, like right where you feel it, you have to use the bathroom and you're actually putting a picture with it, or my heartbeat really fast, like, you know, when you put your hand here and it goes really fast, that actually could be a sign of anxiety. And so kind of going through where are they feeling this? And I know for people even that are neurotypical, if they start understanding that what they're feeling is a normal sign of a mental health disorder, so a normal sign of anxiety, and they can put it on a picture and check off, oh, this is what's happening, it can really decrease the kind of distress that goes with those feelings, because then eventually they'll say, oh, I'm having anxiety. This is a normal symptom for anxiety, and it doesn't feel so overwhelming. So we can do the same thing with people that have cognitive delays as well. Again, you're going to get all those handouts afterwards, not just in the chat, but Kim will also include them in the email that you get after, to make sure you guys could fully download those. Okay. Okay.
Hey, Anne, can I mention something?
Sure.
I know that, I have a specific client who suffers from severe anxiety, and for her, anxiety invokes like a lot of fear. So I really like how you just talked about, identifying those things that they experience as symptoms of anxiety and kind of normalizing it. With her, a lot of her symptoms are physiological.
Mhm.
So helping her to understand that her body is actually reacting the way that it should react in
Right.
situations where she's feeling like that has really helped her to stay more calm during times of high anxiety. So I really
Agreed.
like that you touched on that.
Yeah. Yeah. You're welcome. I appreciate, I know that's big part of it. A big part is that whole secondary anxiety that can come, right? You have the first, and then you have the anticipatory anxiety of, oh my gosh, is my heart beating fast, or am I getting, what's happening? And so your mind just goes crazy on it. So the more that we can give people tools to help them understand, like you mentioned, it's actually your body's working when that's happening. If you wouldn't have those symptoms and you're having anxiety, we'd be worried. But you're having those, that means yes, you have a healthy working body. We just have to figure out how do we eventually get so you have coping, so you have less of those responses as you're going through it. All right, so we want to talk about in order to have someone with a cognitive delay be able to benefit from cognitive behavioral therapy, we have to have some prerequisite skills. And so the first one is we have to be able to have the ability to link a situation to an emotion. So identifying emotions is going to be key. So you're going to want to make sure that, I know someone, which I appreciate, you shared that you make a situation of traffic that you laugh. Well, you want to make sure that you're able to even define it further. And, oh, I link that to feeling happy or joy. Like there's an emotion to it. Laughter would be the behavior that goes with it. So as you're working with the clients, you're going to want to make sure you're helping them to be able to link any situation to maybe an emotion. And that'll get better over time. It might be at first just the most common basic emotions, 5 emotions. And then from there, you can help them to be able to increase the ability to be able to identify emotions. And there's so many worksheets about that. I'll have lots that I'll share with you today to help identify emotions, but you guys have resources too for being able to help identify clients to have them identify different emotions, like the difference between irritability and anger, really being able to get more specific about it. They also need to have the capacity to differentiate between a thought, a feeling, and a behavior. And that's where you want to use those simple worksheets to really help them, and maybe pictures to help them identify that there are really differences between those three. And it's important because the more they can identify the differences, the more they can understand that I can actually right now focus on changing my thought. Maybe tomorrow I'm going to focus on changing my feeling, and the next time my behavior. But each one are separate, and then they actually relate to each other as you go through the cycle, but they have to see them as three different things. And then they have to have an aptitude for correctly identifying the emotions. And again, that's going to be more about working with them, identifying that emotional vocabulary that will get better over time. But that has to be there in order for them to benefit. The other things to benefit are level of comprehension. So I kind of want to open it up. I'd like for you guys just to talk. You don't have to raise your hand. How do you identify someone's level of comprehension? What are current tools that you use now that's helping you to identify that?
I do like a lot of yes and no questions just to see that part first, and then because I have several mostly nonverbal clients, so I try to gauge by yes and no's and see if they will answer that way or head nod. So that's kind of my go-to.
Thank you. Appreciate that. Anyone else have a thought about how do you determine someone's level of comprehension?
I like how the BIMS test is already in Smart Care.
Yep.
So it's right there.
That's awesome.
So that's a tool.
Agree. I like using that too. That's great.
I get a lot of information from like the client's team or their county ISP.
Good. That's a great resource. Absolutely. Yes.
I think their level of education can also come into play, or what type, like were they in a special education or regular education?
Yeah. Agree. Absolutely. Thank you. Does anyone ever test it themselves? Like, how would you test a level of comprehension?
I think you also could have them repeat back what they, back what you said to see if they comprehended what you said to them.
Absolutely.
I try to do that, Pam, and I get repeat it.
Mm-hmm. Yeah, it all depends, right? There are there's a lot of different tools you can use for this. I like the BIMs you guys mentioned. Using what the county gives you could really be good. But honestly, a lot of this is just working with your client. You develop the rapport, and I know sometimes it's like, well, repeat what that might be too much, but it might be you give them options. So maybe something as simple as you read them a paragraph and then you give them three options about what was the main idea. And are they able to do that or not? It's really basic. Again, you're helping them by giving them choices to not make it so overwhelming, but trying to figure out, are they comprehending at all what we're talking about, to make sure they are going to benefit from CBT. Then we look at our level of expression. So how do you guys determine someone's expression? And this is kind of like their like, how are they feeling, basically? So how do you know how they're displaying a different emotion? How would you be able to assess that?
I think being able to recognize their facial expressions, looking at their eyes, their smile, their frown, like the micro expressions.
Yeah. Are they the same for each person?
No, I think that's why it's a good idea to know who, what individual and how they usually express themselves. I've used feeling charts in the past. I've used tension with my clients, explaining body tension, to use it to explain anxiety, how often they're feeling that, when they're feeling that. So
Great suggestions. I love that. Yeah, I used to play a game. It was we would do like a feeling I'd always feeling cards, and like we would take turns where I would pretend I was a feeling and they had to guess what feeling it was, and vice versa. And I mean, everybody thinks you're expressing it a certain way, and then you actually look and it's like, that's what I look like when I'm happy or angry. Like, so helping identify what emotions look like and what it might look like in myself. So good. They also have to have the ability to self-report. So how can you really gauge if someone's able to self-report?
I think a lot of it comes down to knowing your client, like having that rapport built with your client.
Yeah.
I like to use I feel statements and see if they're able to respond back with that.
I like that. Yeah, it's great. And this is too where if someone's nonverbal, you might want to have like those touch boards or some other handouts to help them. So that way, because they're expressing, right? They're still talking to you. It's just not in the same language maybe that you're using. And you want to make sure you have the tools available, because someone being nonverbal does not mean they don't qualify for cognitive behavioral therapy. It just means we need to modify our approach to allow them to have an opportunity to communicate. And then how do you determine self-regulation skills? So again, remember I was talking about that sometimes when you do this, it actually might make the symptoms worse for a little bit. So we have to have a way to be able to help them regulate their skills. So what would be a way you could assess that someone does have some self-regulation skills?
I've asked clients, my clients, situations that have occurred with them. I I have them think about, if you could go back to that situation and redo it all again, what would you do? And I've had some people tell me like, well, I wouldn't have I wouldn't have lashed out on my peer. I would have just let it go if they said something mean to me first.
Yeah, I like that. That's a great way of doing it. Absolutely. So I'm giving you this because I want you to know if you're going through CBT with a client, you're not really making headway, just verify that they hit these 4 areas. Because again, this has to be a necessary prerequisite for someone to be able to benefit from cognitive behavioral therapy, is these 4 areas. So spend some time getting to know them and figure out if you have a good understanding of this as you're going through the cognitive behavioral process with the client. So again, we're going to be able to make sure that we are trying to modify our approach based on that person's cognitive capacity. There's not a lot of research that supports someone that has profound developmental disabilities to be able to benefit from this, but there definitely is people that have moderate and mild that could benefit from it. So just make sure that everything happens, that the learning disability, cognitive delays can happen on a continuum. So even if they're labeled a certain way through the board, know that they still might benefit. So you want to make sure that you're looking at if this is going to be beneficial to the person. And I talked already about modifying. Here's one of those feeling charts. Like I said, I'm going to send you all these resources that'll have things on there. And I'd love for you guys to share even more that you have. I know some people put stuff in the chat, which is great. We can kind of compile all that together as well when we send out information to you. Because although I said there's tons of research that this will work for people with cognitive and intellectual development disabilities, including autism, unfortunately, there is not a lot of actual hands-on resources for people to use when they're working with that population. So most people are just creating their own things. So if you have things, I know that we would benefit so much if you're willing to share any of the resources so that we can also use them. Some real quick, real simple stuff that you're going to modify for each individual, obviously slower pace, repetition. You're going to encourage overlearning. So basically what this means is you may be going through one ABC round for the whole entire session. And that's okay. Like you're going to go very slow through this process because you're going to want to make sure they're retaining the information. And that it's at a, that overlearning that needs to happen. Someone needs to hear and experience something many, many times before they're going to start being able to get over that negative, irrational thought pattern that automatically comes. Also, doing some role play can be fun, and visual processing. Again, tailoring all the exercises as much as you possibly can, using the simple languages as much as possible too, breaking down stuff into smaller, more manageable steps. All right, we're not gonna do another breakout room. So some of the characteristics that you need to have as a therapist, nurse practitioner, nurse, TBS, you need to be warm, have an empathetic approach. Remember that you're gonna probably need to have a lot of positive reinforcement, friendly attitude as you go through stuff. You're gonna wanna make sure that they're seeing you as genuine, being honest. You wanna make sure that, they're remembering someone with depression that we talked about is going to look through things through a negative lens. So making sure they may misinterpret what you're trying to say and kind of expect that, but being genuine and honest as you're going through this, having that warmth as well. And then build rapport. Building rapport is going to take a very long time. Remember, a lot of times people, especially with developmental disabilities, people come and go out of their life all the time. So the more that you can develop a strong, stable relationship with them where they feel safe and secure, then they're going to be able to try this. Because again, remembering this might actually feel worse before it feels better. That rapport is where it's going to be real essential that they feel safe with you. You're going to have that therapeutic alliance. And again, we're challenging the person. So even though you know that what you could label it as they're having an irrational thought about, I mentioned the spider before. So let's say you meet with me the very first time and I say, I'm really scared of spiders. If you just say, well, stop thinking that way, or what's another way you can look at it? Okay, from now on, look at it that way. That's not going to work for me, right? Because it's so ingrained. So you want to make sure that you're remembering it's going to take a while. You might just identify that they have that before you even say that's kind of irrational. You may just help identify the identification for several sessions and then get into, well, what could be a possible alternative way to think about that? Maybe not labeling it irrational yet, but labeling as what's an alternative way of looking at it. Again, that therapeutic approach is so important, having accurate empathy too. And then you're going to look at the therapeutic alliance. How can you you want to make sure that you're working on looking at their nonverbal cues, communicate. So again, a lot of you already are working with clients on a regular basis, getting to understand how someone with any kind of cognitive delays might express their depression, anxiety, other symptoms differently than someone that's neurotypical. But some of you, this is the very first time, and you've never worked with this population. And it's like, how do I go about doing this? Just know it's going to take a little bit, and that's okay. Work a lot with your supervisor to figure out how can, getting consultation about how to help with this. But it's going to take a while. It takes people years of working with someone with cognitive delays before they really start able to see, oh, I know how now I can really modify my approach. So don't feel bad if that's you. We're all on learning together. So just work with your team on developing, asking for more resources and actually going through cases with them so they can help give you more ideas about how to continue to develop that therapeutic alliance with the client. And then accurate empathy, I talked about that a little bit. How you want to have cultural sensitivity as well. Remember that, in the midst of all this happening, someone has a co-occurring cognitive delay, they also may have their own cultural sensitivity. They may have different, everybody all have our own different race. We have a different culture. We have different gender, whatever. Like we have to make sure that we're also looking through those lenses too. So just always keep that in the back of your mind too, as you're approaching things. So I wanted to talk just real briefly about the role of the caretaker support. So most of the people we work with that have a cognitive delay have a very involved caretaker or support worker. It may not be I don't know, there's all kinds, right? So when you're in the nursing home, you're going to have people that are nursing assistants, nurses, other people like that. They're going to be around. And that's not always a good or a bad thing. So there could be a negative influence in the fact that their involvement could actually make things worse because maybe that person's being dependent on them or heavily involved in them as far as like if they're always used to looking to that person for like if you'll say, oh, how you feeling today? And they always look at the other person to tell you how they're feeling, know you're probably going to want to work on that and figure out how can we maybe involve the person, but also have that the individual you're working with be able to get to the point where they're speaking on their behalf. Again, you're going to continue. You're not going to challenge this right away. This is just going to be something for you to keep in mind as you're getting closer in that therapeutic relationship. Because remember, the aim of anybody involved in CBT is to be their own therapist. Same thing with people with cognitive delays. You eventually don't want to have a job. You want to make sure that they can eventually use these skills to be able to look through life in a different lens and not automatically have that, irrational thoughts, emotions, and behaviors that can be either they're seeing other alternatives. So again, we talked about this a little bit, but the suggestivity that can happen. So remember that there's people that can have, I think Laura mentioned this a little bit, basically where you're asking somebody about something they just repeat, or they could be more susceptible to leading questions. So you want to make sure that, you're paying attention to that and that you're really trying to figure out how can I identify what's normal and baseline for this person? How can I really get to know them? And again, they're coming to this with years of experience, knowing, hey, if I say things a certain way, I'm going to get a certain reaction. And it's become now, the lens through the way they see things. So that suggestibility can be part of that. Ooh, I like try to get this whole 2 hours in this amount of time. And I did it because our owner and president really believes in you guys celebrating holidays. And so the day before a holiday, he likes to give people extra time off. So you guys could have it. I know some of you already have people scheduled. Please keep that. I don't want to disrupt that. But if you're able to, after this meeting today, you're able to talk to your supervisor, but you are able to have the rest of the day to enjoy an early start to the holiday. Before we end, I want to see if you guys have any questions. How about those of you that said you were skilled from the beginning? Anything that I missed today you think is really important for this group to hear? I'm looking at, oh yeah, good. I'm looking at some people I know are really skilled and I'm like waiting for you to say something. Like Teresa, I know is really good.
I think it's Allie. I think that the most important takeaway from today is just like the way that people think, and being able to restructure the ways that they think and look at things. That's probably the key point and the most important way to be able to work with a client and have them develop the skills that they need, because a lot of people just need to understand the why. It can be scary and confusing when they don't understand why they're having symptoms or, what their symptoms mean. So, just kind of looping it back to changing the way that they think about things and really helping them to understand their diagnosis, like a huge part of it.
Yes, good. Thank you, Allie. I appreciate that so much. I know you've been working with this population for years, and that's really helpful guidance from you. So I want to say this, you guys are gonna get a lot of resources. So take what you can out of it. And then just reach out to your supervisor for assistance as you're going through this. Also, please feel free to reach out to me. I've been doing CBT for a long time and I find it very valuable, but it doesn't actually start getting challenging until you're working with clients. And so if that happens, don't feel like this is a one and done training. We want to be here to support you because we really definitely want to make sure that this is again, a very evidence-based approach. that all of you guys can do with our clients, and they will benefit greatly. Okay, so I guess anything else? All right, Kim, I'll let you jump on. Is there anything other recap you need to do?
No, just to refresh everyone's memory after the training today, I'll be sending out an email with the evaluation, all of the handouts that Anne referenced, a PowerPoint of her presentation. If you could return that evaluation in 5 business days, that'd be great. So I can get you your certificate of attendance, and let us know if there's anything else that you need. Thank you, Anne. Great training and great resources.
All right, happy Memorial Day, guys. Enjoy your long weekend. You deserve it.
Thank you.
You too,
Thank
Anne.
you.
Thank you. All right, thanks.